Welcome to the deep dive. Have you ever considered how those microscopic pills we take actually tackle these, well, pretty formidable bacterial infections? What makes one antibiotic a hero, while another just kind of stands by? And what about this growing shadow of antibiotic resistance? It's a challenge that touches everyone, right? From our personal health to, well, global public well-being.
Indeed. The ongoing battle against bacteria is absolutely one of the most critical frontiers in modern medicine. We're facing an era where common infections could become incredibly difficult, maybe even impossible to treat. So a deep understanding of these mechanisms is more vital than ever. Today, we're not just skimming the surface, we're really embarking on an in-depth exploration, a deep dive into the fascinating world of antibacterial agents that specifically target a bacterium's most fundamental shield, its cell envelope.
That's exactly our mission. We're taking this stack of highly detailed sources, the kind of, medical professionals meticulously study, like GOODMAN and GILMAN's, and we're extracting the most important nuggets of knowledge for you. Whether you're preparing for a critical meeting, maybe catching up on developments in the field, or if you just possess an insatiable curiosity, by the end of this deep dive, you will grasp the intricate mechanisms, the historical milestones, and the pressing challenges in this vital area. You'll have the kind of comprehensive understanding that truly sets the elite professionals apart.
Absolutely. You'll gain a profound appreciation for how these drugs actually achieve their effects, why bacteria develop resistance, which is a huge issue, and what these evolving dynamics mean for the future of treatment. We'll explore the why and the how behind every concept, ensuring you don't merely accumulate facts, but you truly internalize their significance. As you mentioned, our primary source is a comprehensive excerpt from GOODMAN and GILMAN's The Pharmacological Basis of Therapeutics, a foundational text. It's incredibly rich with precise scientific detail covering everything from, say, the molecular structure of antibiotics right through to their clinical applications and, crucially, the complex strategies bacteria employ to defend themselves.
Okay, so we'll begin by understanding the bacterial cell itself, particularly its outer defenses. Then we'll unravel the different classes of cell envelope disruptors. We'll dive deep into their precise mechanisms, their spectrums of activity, which bugs they hit, how our bodies handle them, and the crucial evolving ways bacteria are developing resistance against them.
Exactly. Prepare for some genuine aha moments as we connect the dots between, complex molecular chemistry and real-world clinical implications. This won't feel like listening to a textbook, I promise. It'll be an engaging journey of discovery, really designed to give you a true mastery of the subject matter.
All right, so to truly grasp how these remarkable drugs work, we must first understand their primary target, the bacterial cell envelope. You described it as the bacterium's protective suit, right? Its intricate, multi-layered defense against the outside world and critically against our antibiotics.
Precisely. The typical bacterial cellular envelope is a complex, really quite formidable structure. At its core, you've got the inner membrane. Think of it like our own cell membranes regulating what goes in and out. External to this is the cell wall, a critically important layer. It provides structural integrity. Mechanical stability basically keeps the bacterium from bursting. And then for a specific type of bacteria we call gram-negative organisms, there's an additional outermost layer, the outer membrane. This entire envelope system, it's a prime target. Disrupting any part of it often proves lethal for the bacterium.
And it's those fundamental structural differences between gram-positive and gram-negative bacteria that are absolutely crucial, aren't they? They dictate so much about how we categorize them and, more importantly, why certain antibiotics work on one type but are useless against another.
They are indeed foundational. Let's compare these two major groups. In gram-positive bacteria, the cell wall is remarkably thick. We're talking 50 to 100 molecular layers thick. This robust peptidoglycan polymer, which gives it incredible strength, is located very close to the cell surface. It also often contains things like lipoic acid, which plays roles in adhesion and immunity. Now, for most smaller antibiotic molecules, this thick wall is generally quite permeable. It allows them relatively straightforward access to their targets either within or just beneath it.
Okay, that makes sense for gram-positives. But then the gram-negative bacteria, you said they present a much tougher challenge. That additional outer membrane sounds like a formidable barrier.
They certainly are tougher in that regard. In gram-negative bacteria, the cell wall itself is much thinner, maybe only 1 or 2 molecules thick, and it's nestled within a compartment called the periplasmic space. This space is sandwiched between the inner membrane and that defining feature, the outer membrane. Sometimes there's even an external capsule layer. Now, that outer membrane acts as an extremely effective barrier. It often makes the bacterium, quote, impenetrable to many antibiotics. It has a unique composition featuring lipopolysaccharide, or LPS, on its outer surface. LPS itself is a potent molecule. It can trigger strong inflammatory responses in us. For antibiotics to even get through this outer membrane, they generally must pass through specific protein channels known as porin channels.
Porin channels, okay. So like little doorways through the outer wall.
Exactly. But the number, the type, the size of these porin channels can vary significantly among different gram-negative species, and that directly impacts their susceptibility to various antibiotics. Furthermore, that periplasmic space, the area between the inner and outer membranes, is a critical location. Certain enzymes, like the lactamases we'll discuss later, can hang out there and effectively inactivate antibiotics before they even reach their intended targets deeper inside.
Wow. So these structural differences aren't just, interesting biological facts. They are the fundamental reason why a drug might work against, say, a strep infection, but be completely ineffective against E. coli. It really impacts drug access and treatment choices.
Exactly. The implications are profound, and they directly influence our therapeutic strategies. The distinct architectures dictate whether a drug can even reach its target PBP on the inner membrane. Drugs that are too large, or perhaps too hydrophobic water-hating, often just cannot navigate that gram-negative outer membrane. This renders them useless against those bacteria. That's why understanding these layers is absolutely essential for predicting and optimizing antibiotic efficacy.
Got it. And what are the main classes of antibiotics that directly target these vital cell envelope components, the big hitters?
Broadly speaking, we primarily focus on three major classes here. First, the Lactam antibiotics, which is a huge group encompassing penicillins, cephalosporins, carbapenems, and monobactams. Second, the glycopeptides, with vancomycin being the classic example. And third, the lipopeptides, such as daptomycin. There are also other, maybe less commonly used classes like bocetracin, which we'll touch on, and polymyxins, though those are technically outside this specific deep dive. But these are the powerhouses targeting the bacterial outer layers.
Okay, let's now immerse ourselves in the β-lactam antibiotics. You mentioned they are arguably the single most important class in our antibacterial toolkit. What makes them so indispensable, and what's the common thread uniting them all?
Well, what brings together penicillins, cephalosporins, carbapenems, and monobactams, despite their, very diverse clinical uses, is a common structure, the lactam ring. This unique four-membered nitrogen-containing ring structure is absolutely essential for their antibacterial activity. And their unifying mechanism of action is profound. They all work by inhibiting the synthesis of the bacterial peptidoglycan cell wall. That's the key target.
And what makes them so crucial clinically? Why are they the most important?
Their clinical importance really can't be overstated. They offer a broad and varied spectrum of activity, meaning they can effectively come at a huge range of bacterial infections. They provide potent antibacterial killing. They often clear infections rapidly. And generally, they possess favorable tolerability, meaning fewer severe side effects for patients compared to many other drug classes. However, and this is a big however, we have to acknowledge the persistent shadow of resistance. Resistance to β-lactams has steadily increased over time. It's a massive challenge. And this escalating challenge is precisely what drives the continuous development of new agents, like, say, cephalosporin, designed to evade these resistance mechanisms, or the lactamase inhibitors, which are co-administered specifically to neutralize the enzymes bacteria use to break down these crucial drugs.
Okay, so how do β-lactams actually achieve this cell wall inhibition at a molecular level? What exactly are they disrupting in that peptidoglycan synthesis pathway?
This is where the core ingenuity of these drugs really lies. The bacterial cell wall, as we discussed, is primarily composed of this heteropolymeric peptidoglycan. Think of it as a meticulously constructed, rigid chain link fence. It gives the bacterium its mechanical stability, its shape, essentially its skeleton and armor combined. This peptidoglycan is built from linear glycan chains, long sugar strands. These sugar strands are then cross-linked by short peptide chains, creating an incredibly strong interconnected network. Now, the initial steps of this elaborate construction, the precursor formation, they begin inside the bacterial cytoplasm. Here, the building blocks are made. These precursor units are then transported outside the plasma membrane, and it's out there where they're linked together to form long polymers. The absolutely crucial last step that completes this cross-linking process is a transpeptidation reaction, which occurs outside the plasma membrane. This is the moment when that bacterial fence truly becomes strong and rigid.
And that's precisely where the β-lactams launch their attack, right? Disrupting that final cross-linking step.
Exactly. As pharmacology texts like GOODMAN and GILMAN illustrate, β-lactam antibiotics inhibit this last step in peptidoglycanin synthesis. They achieve this by essentially acylating the transpeptidase. To simplify, they form a permanent covalent bond with the transpeptidase enzyme. They effectively jam its active site, rendering it completely unable to perform its vital cross-linking function. This acylation happens through the cleavage of the HEO-N bond of the win-lactam ring. When that bond breaks, the antibiotic becomes irreversibly bound to the enzyme. It's essentially a suicide inhibitor. It sacrifices itself to disable the enzyme.
So the lactam ring isn't just a structural tag. It's the actual part of the molecule that breaks to disable the bacterial machinery. And these transcriptidases, they're also collectively known as penicillin-binding proteins, or PBPs.
Yes, exactly. Penicillin-binding proteins, PBPs, is the collective term for these transpeptidase enzyme targets that β-lactam antibiotics aim for. Now, it's important to understand that bacteria don't just have one single PBP. They actually produce multiple functionally related but distinct PBPs. What's more, each of these different PBPs can have varying affinities for individual carbapenems. This variation helps explain why different lactam drugs might be more effective against certain bacteria than others. And the lethality, how these drugs actually kill the bacteria, involves both enzymatic and non-amylotic mechanisms. Essentially, inhibiting some specific PDPs is more consequential for leading to the breakdown of the cell wall and ultimately bacterial cell death or lysis.
That's a really powerful mechanism. But as you alluded to earlier, bacteria are incredibly adaptable. What are the main ways they're fighting back against these crucial lipopeptides?
Ah, yes, the escalating challenge of bacterial resistance. It primarily arises from three major mechanisms. Understanding these is absolutely fundamental to grasping the current landscape of antibiotic therapy and why we face the challenges we do. First, we have alterations in the PBP target itself. This means the bacterium subtly changes the very proteins that the β-lactam antibiotics are designed to bind to. This can happen through simple mutations that decrease the PBP's affinity for the antibiotic, basically making the drug less sticky and therefore less effective. Or alternatively, a bacteria might acquire entirely new PBPs, often through plasmid transfer, that's how bacteria share genetic info, or through homologous recombination. These new PBPs inherently have a very low affinity for β-lactams right from the start.
Can you give us a couple of clear examples of this PDP alteration in action?
Certainly. A classic and highly concerning example is methicillin-resistant Staphylococcus aureus, or MRSA, and its close relatives, the coagulus-negative Staphylococci. These bacteria become resistant mainly by acquiring an additional high molecular weight PBP, specifically one called PBP2A, via a mobile genetics element, a transposon. Now, this newly acquired PBP has a very low affinity for all the lactam antibiotics. That renders the entire class, with maybe one or two rare exceptions we'll discuss later, largely ineffective against these formidable pathogens. It's a primary reason MRSA infections are so tough to treat. Another important example is Streptococcus pneumonia. Highly penicillin-resistant strains showed decreased affinity in some of their key PBPs, often due to picking up genetic material from related species. Generally speaking, resistance through PBP alteration is more common among gram-positive versus gram-negative bacterial pathogens, largely because their PBPs are structurally more directly accessible to the drugs.
Okay, that makes perfect sense. If the drug can't bind effectively, it simply can't work. What's the second major mechanism of resistance then?
The second mechanism is reduction of concentration at the target site. This is all about the antibiotic simply not being able to reach its intended target inside the bacterial cell in sufficient amounts to be effective. And as we discussed, those structural differences between gram-positive and gram-negative bacteria are paramount here. In gram-positive bacteria, remember, the peptide glycan polymer is very near the cell surface. This allows small lactam molecules to easily penetrate down to the outer layer of the cytoplasmic membrane where the PBPs are located. It's a relatively straightforward path. However, for gram-negative bacteria, it's a completely different ballgame. Their outer membrane functions as an impenetrable barrier for many antibiotics. While some small hydrophilic antibiotics can diffuse through those aqueous channels, the porins we mentioned in this outer membrane, the number and size of pores can vary among different gram-negative bacteria. This directly impacts how much antibiotic can actually get through to the periplasmic space and reach the inner membrane PBPs. This variation provides a significant built-in resistance advantage for certain strains.
And then there are those active efflux pumps you mentioned earlier, right? Like a bouncer literally kicking the antibiotic out before it can even get to work.
Exactly. These active efflux pumps are another incredibly clever resistance mechanism. They are sophisticated protein systems embedded in the membranes that quite literally remove the antibiotic from its site of action before it can act. What's remarkable is that in gram-negative bacteria, these pumps can traverse both inner and outer membranes, acting like a multi-stage pumping system. They are energized by the proton motive force, a form of energy for the cell, and increased expression of these pumps, basically, the bacteria making more of them, is a significant cause of antibiotic resistance because they can just continuously pump the drug out, ensuring it never reaches a lethal concentration inside.
Wow. So even if the drug manages to squeeze past the outer membrane, it can just be actively pumped right back out again. Yeah. What's the third major mechanism?
The third primary mechanism, and arguably the most prevalent and concerning for β-lactams, is enzymatic degradation by β-lactamases. Bacteria produce these enzymes, all-lactamases, that directly hydrolyze the all-lactam itself. They do this by breaking that critical all-lactam ring structure we talked about, rendering the antibiotic completely inactive.
Like a molecular pair of scissors snipping the drug.
That's a great analogy. And there's an astonishing diversity of these enzymes. Thousands of different β-lactamases have been characterized, and their substrate specificities range from being relatively narrow, maybe only hitting certain penicillins, to incredibly broad, capable of hydrolyzing almost all β-lactams. The quantity and strategic placement of these enzymes also differ between gram-positive and gram-negative bacteria, giving them different advantages. In gram-positive bacteria, they typically produce and secrete a large amount of lactamase, usually narrow-spectrum penicillinases. A classic example is the staphylococcal penicillinase, often encoded on plasmids and inducible, meaning it's easily transferable and can be ramped up when penicillin is present. In contrast, gram-negative bacteria generally produce lower quantities of lactamases, but their strategic placement makes them incredibly effective. They are located in the periplasmic space, that critical area between the inner and outer membranes. This provides maximal protection for the microbe, as the enzyme can inactivate the antibiotic before it even reaches the critical PBP targets on the inner membrane. These bactamases in gram-negatives can be chromosomally or plasmid encoded, and their expression can be constitutive, always on, or inducible.
And then we hear about these carbapenems that sound particularly terrifying.
Yes, carbapenems are of particular concern. These are a specific, nasty type of lactamase capable of hydrolyzing not only penicillins and cephalosporins, but also the carbapenems, which are often considered our last resort β-lactam antibiotics. Microorganisms expressing these carbapenems, especially when combined with other resistance mechanisms like efflux pumps or porin loss, may be resistant to all or almost all antibacterials in clinical use. This leaves us with very few, if any, treatment options, which is a major public health crisis.
So it's not always just one mechanism at play. Bacteria can employ multiple defenses simultaneously.
Absolutely. It's rarely just one thing. More than one of the aforementioned resistance mechanisms may be present in a pathogen, and they can work in concert to confer resistance. It's often a multi-pronged attack on the drug. Furthermore, the local environment can also contribute to resistance. For example, microorganisms adhering to implanted prosthetic devices, think catheters, artificial joints, heart valves, often produce biofilms. These bacteria secrete a protective extracellular matrix made of stuff like polysaccharides, proteins, and DNA. Bacteria huddled within these biofilms are much less sensitive to antibiotic therapy. This is partly due to decreased growth rates. Slower growing bacteria are less susceptible, and also reduced drug penetrance into that dense, slimy matrix. It's like a fortified city for bacteria. Beyond that, the growth phase of the bacteria also matters significantly. β-lactam antibiotics are most active against bacteria in the logarithmic phase of growth. That's when they're rapidly multiplying and actively building lots of new cell wall material. They have little effect on microorganisms in the stationary phase, when growth has slowed down. Similarly, bacteria that manage to survive inside viable cells of the host, certain intracellular pathogens generally are protected from the action of the β-lactam antibiotics simply because the drugs can't easily reach them inside our own cells. This limits the effectiveness of lactams against those specific types of infections.
It really sounds like an uphill battle sometimes. But we are developing ways to fight back, aren't we? Particularly against those old lactamases. What are those strategies?
That brings us neatly to the melalactamase inhibitors. Because melalactamases play such a key role in conferring resistance, an increasing number of eulactams are now co-formulated with molecules whose sole role is to protect the melalactame from the malactamase. These inhibitors effectively bind to and prevent the allolactamases from hydrolyzing the actual lactam antibiotic, essentially acting as a shield, allowing the antibiotic to then go and successfully do its job on the PBPs. Historically, we've had what we now call the older generation β-lactamase inhibitors, such as clavulanate, sulbactam, and tazobactam. These are quite effective at inactivating many of the common plasmid-encoded lactamases, which were a huge problem. However, they do have significant limitations. They fail to provide protection at clinically achievable concentrations against the bactamases. These are the ones chromosomally encoded in some really tough gram-negative bacilli like Enterobacter, Citrobacter, and Pseudomonas. They also don't work against the really concerning carbapenems of the KPC type or the metallo-lactamase type. Let's take clavulanic acid as an example. While it has poor intrinsic antimicrobial activity by itself, it's an irreversible mechanism-based inhibitor that effectively binds to a wide range of β-lactamases. It's most commonly combined with amoxicillin as an oral preparation. You probably know it as Augmentin, and it used to be combined with ticarcillin for IV use. Sulbactam is structurally similar to clavulanic acid. It's available for intravenous or intramuscular use combined with ampicillin, unicin. Interestingly, sulbactam itself possesses intrinsic activity against Acinetobacter spp, making that combination useful for certain multi-drug-resistant Acinetobacter infections. Tazobactam has good activity against many of the plasmid-mediated vancomycins, including some of the extended spectrum types, ESBLs. It's primarily available as parenteral combination products with piperacillin, Zosyn, and also now with ceftolozane and Zerbaxa. These combinations significantly broaden the spectrum of the co-formulated antibiotics, making them much more versatile.
It's definitely good that we're constantly developing new tools for this ongoing fight. What about the newer generation inhibitors you mentioned? How are they different?
Right. These newer generation inhibitors are a critical development because they are structurally dissimilar from the older ones and, importantly, boast a broader spectrum of inhibition. Two key examples are avibactam and relebactam. These are novel non-β-lactam lactamase inhibitors. They provide clinically useful inhibition against both narrow and extended spectrum lactamase, ESBL type, chromosomal AMPC, and critically KPC type β-lactamases. This activity against KPC enzymes is a huge improvement, as KPCs are major drivers of carbapenem resistance. However, it's crucial to note that they are not effective against metallo-lactamases. That's a different class of enzyme they don't inhibit. Abactam is currently co-formulated with ceftazidime, Abicaz, while relebactam is co-formulated with imipenem-cilastatin, Regarbrio. And then there's vaborbactam. This one is chemically distinct. It's a novel boronic acid-based non-lactam lactamase inhibitor. It provides a broad inhibition of lactamases similar to abibactam and relebactam, offering a similarly powerful shield against many problematic resistance enzymes, including KPCs. Vaborbactam is co-formulated with meropenem, Vabomere. These newer inhibitors really represent a significant step forward in our ability to overcome the ever-growing threat of lactamase-mediated resistance, especially in those difficult gram-negative infections.
Okay, now let's turn to the class that truly revolutionized medicine, the penicillins. It's just remarkable to think about the impact of this single drug, how it literally changed the course of human history. Can you take us back to that miracle of its discovery?
It truly is one of the most remarkable stories in medicine, yeah. Our journey begins back in 1928 with Alexander Fleming in London. While he was studying Staphylococcus bacteria, Fleming made this, serendipitous observation. A mold contaminating one of his cultures caused the bacteria nearby to undergo lysis. Basically, they burst open and died. Recognizing its potent antibacterial properties, he identified the mold as a species of penicillium and named the active substance penicillin.
But it wasn't immediately a usable medicine, was it? It took quite a bit more effort to actually turn that observation into a therapeutic drug.
That's absolutely correct. It took another decade or so. In the late 1930s and early 1940s, a group of investigators at Oxford University, notably Florey, Chain, and Abraham, did the critical work of developing penicillin into a systemic therapeutic agent. By May 1940, they had a crude preparation, and it produced these dramatic therapeutic effects when given to mice suffering from streptococcal infections. This initial success paved the way for human trials in 1941. They were using incredibly scarce and impure preparations to treat desperately ill patients. There are famous anecdotes about recovering penicillin from patients' urine just to re-administer it, highlighting the sheer scarcity and the urgent need at the time.
From those really humble, almost makeshift beginnings, how did it scale up to mass production so relatively quickly?
The major breakthrough came with a vast research program initiated in the U.S. during World War II. The development of the deep fermentation procedure for the biosynthesis of penicillin marked a crucial advance for large-scale production. This innovation led to an absolutely explosive increase in manufacturing. From mere hundreds of millions of units a month, production soared to over 200 trillion units by 1950. And concurrently, the cost plummeted dramatically, from several dollars for a dose down to just a few cents, making it widely accessible. It truly transformed medicine, offering a powerful weapon against infections that were previously often fatal.
What's the basic chemical blueprint of all penicillins? What makes them unique within that structure?
Okay, at their core, all penicillins share a basic structure. You have a thiazolidine ring connected to a lactam ring, B, to which is attached a side chain, R. That core, the penicillin nucleus itself, including that essential lactam ring, is the chief structural requirement for its biological activity. The real brilliance of penicillin development lies in these side chain modifications. By attaching different R groups onto that core structure, scientists could cleverly alter the susceptibility of the resulting compounds to inactivating enzymes like vt-lactamases. They could also improve their affinity for PBPs, enhance the ability of the drug to traverse the outer membrane of gram-negative bacteria, and even change the pharmacokinetic properties of the drug, influencing how the body absorbs, distributes, metabolizes, and eliminates it. It's all about tweaking that R group.
And how are penicillins generally handled by the body, in terms of distribution and getting rid of them?
Generally, penicillins are distributed widely throughout the body. They reach therapeutic concentrations in various tissues and secretions, including places like joint fluid, pleural fluid around the lungs, pericardial fluid around the heart, and bile. However, they generally achieve only low concentrations in some more challenging areas like prostatic secretions, brain tissue itself, and intraocular fluid inside the eye. Now, when it comes to the cerebrospinal fluid, or CSF, surrounding the brain and spinal cord, penicillin penetration is variable. In normal, healthy meninges, concentrations are minimal, less than 1% of what's in the plasma. But importantly, when there's inflammation, like in meningitis, concentrations in the CSF can increase to as much as 5% of the plasma value. This can be enough to be therapeutically effective if the microorganism is sufficiently susceptible. Penicillins are eliminated rapidly by glomerular filtration and renal tubular secretion in the kidneys. This gives them a short half-life, typically around 30 to 90 minutes. This rapid clearance results in high concentrations of these drugs in urine. Since the drug is primarily eliminated by the kidney, though some is metabolized, dosage adjustment is therefore required for patients with significantly impaired renal function or those on dialysis. You have to account for the kidneys not clearing it as fast.
That's a really clear picture of how they move through the body. Now, let's break down the specific classes of penicillins, starting with the original ones, penicillin G and penicillin V. What's their core activity, and why are they still relevant today?
Okay, so penicillin G, which is given by injection, and penicillin V, which is taken orally, have similar antimicrobial spectra, especially for aerobic gram-positive microorganisms. Most streptococci, including Streptococcus pyogenes, the cause of strep throat, remain susceptible. However, we are seeing increasing resistance in penicillin-resistant viridin streptococci, and concerningly in S. pneumonia pneumococcus. For S. aureus, the vast majority of strains, over 90%, are now resistant to penicillin G due to penicillinase production. However, Neisseria meningitidis meningococcus generally remains quite sensitive. They are also highly effective against most anaerobic gram-positive microorganisms, including things like Clostridium cepi, like the cause of gas gangrene, and they're very effective against spirochetes, like Treponema pallidum, the cause of syphilis, and Borrelia burgdorferi, Lyme disease. It's important to remember, though, that penicillins are not effective against amoebae, plasmodia, rickettsia, fungi, or viruses, because they specifically target bacterial cell wall synthesis.
You mentioned penicillin V is preferred orally. Why is that? And then what are those long-acting forms of penicillin G for?
Right. For oral administration, penicillin V is superior to penicillin G because it's more stable in an acidic medium, meaning it survives the stomach acid better, and therefore it's better absorbed from the GI tract. You get higher plasma concentrations with V than G orally. Absorption is generally rapid, and it's usually advised to administer oral penicillins at least 30 minutes before a meal or 2 hours after because food can interfere with absorption. Now, to prolong the effect of penicillin G, which has a short half-life, we use repository preparations like penicillin G benzathine and penicillin G procaine. Penicillin G benzathine in particular releases penicillin G very slowly from the injection site, producing relatively low but persistent concentrations in the blood for weeks, sometimes up to 26 days. This makes it ideal for certain long-term treatments like syphilis, where you need sustained levels. But there's a crucial safety note here. Neither depot formulation should be given intravenously, as serious toxicity can result. This includes things like procaine toxicity or even cardiorespiratory arrest and death with benzathine if given IV. These are strictly for deep intramuscular injection only.
Okay, very important safety point. So, given their activity, what are the key therapeutic uses for penicillin G and B today? Where do they still shine?
Well, for pneumococcal infections, penicillin G remains a primary choice if the strain of S. pneumonia is known to be sensitive. However, because of increasing resistance for severe infections like pneumococcal meningitis, empiric therapy usually involves combination therapy, often vancomycin plus a third-generation cephalosporin, until sensitivity results are back. For mere hemolytic streptococcal infections like strep throat caused by Streptococcus pyogenes, oral penicillin V for 10 days is still the preferred therapy. It's effective, and importantly, it reduces the risk of developing acute rheumatic fever later on. For syphilis caused by Treponema pallidum, penicillin G benzathine is highly effective and remains the drug of choice for all stages. Even in pregnant women who are allergic, desensitization is recommended because there are no proven alternatives. It's also the agent of choice for Listerian infections, Listeria monocytogenes, especially in immunocompromised patients who get meningitis from it, often combined with gentamicin in those cases. And penicillins are still vital for certain prophylactic uses, like preventing recurrent rheumatic fever in susceptible individuals or preventing serious bacterial infections in patients who have had their spleen removed, asplenia.
Okay, moving on from the originals. What about the penicillinase-resistant penicillins? As their name suggests, they were specifically developed to overcome that pesky penicillinase enzyme produced by staph.
Exactly. This group includes drugs like oxacillin, dicloxacillin, and nafcillin. They are specifically designed to be resistant to hydrolysis by staphylococcal penicillinase. Because of this, they are the preferred agents for treatment of penicillinase-producing S. aureus and Staphylococcus epidermidis that are not methicillin-resistant. So for MSSA, methicillin-susceptible Staph aureus, however, it's absolutely vital to grasp the challenge of MRSA, methicillin-resistant S. aureus, and MRSE, methicillin-resistant S. epidermidis. These organisms, as we discussed, acquire that altered PBP, PBP2A, that renders them resistant to all lactamins with the exception of ceftaroline. So for MRSA or MRSE infections, alternative agents such as vancomycin or daptomycin are typically required. These penicillinase-resistant penicillins are generally less potent than penicillin G against microorganisms that are sensitive to pen G, and importantly, they are not active against Enterococci, Listeria, or gram-negative organisms. A notable pharmacokinetic feature is that while they're primarily eliminated by the kidney, they also undergo significant hepatic degradation. And remarkably, no dosing adjustments are needed for patients with renal failure, which can be useful. Their main uses are for confirmed or suspected MSSA infections, ranging from skin and soft tissue infections using oral dicloxacillin or parenteral nafcillin to serious MSSA infections, such as endocarditis, where higher doses are needed.
Got it. Let's move to the next group, the aminopenicillins, ampicillin and amoxicillin. These seem to have a different strength compared to the penicillinase-resistant ones, broadening the spectrum maybe.
That's exactly right. The aminopenicillins, which primarily include ampicillin and amoxicillin, were developed to expand the spectrum of activity of penicillin G. They achieve this by providing useful activity against more gram-negative organisms than the original penicillins. However, there's a catch. They are hydrolyzed by palliamases, both the gram-positive kind, like staphylococcal penicillinase, and many gram-negative beta-lactamases. This means their activity against many common pathogens is often restored through co-formulation with pallolactamase inhibitors, like clavulanate, making amoxicillin clavulanate or augmentin, or sulbactam, making ampicillin-sulbactam or mesin. Amoxicillin spectrum is essentially identical to that of ampicillin, with maybe a minor exception for shigellosis, where ampicillin might be slightly better. For gram-positives, they are broadly similar to natural penicillins, but pneumococcal and viridans group Streptococci show variable resistance. If it's penicillin-resistant, it's usually ampicillin or amoxicillin-resistant too. Against gram-negatives, many strains of H. influenza and some E. coli are susceptible if they don't produce lactamases. Now, an important practical point. Amoxicillin is generally preferred over ampicillin for oral administration. Why? Because it's absorbed more rapidly and completely from the gut, and crucially, food does not interfere with absorption, unlike ampicillin. This also leads to less diarrhea with amoxicillin. Their main therapeutic uses include respiratory infections like sinusitis, otitis media, bronchitis exacerbations, where amoxicillin is actually the most active oral bacterial against S. pneumonia. High-dose amoxicillin is often recommended for empiric treatment of ear infections in kids due to resistance patterns. They are also used for urinary tract infections, although high rates of E. coli resistance make empiric use challenging without an inhibitor. For enterococcal bloodstream infections and endocarditis, high-dose ampicillin is often considered the drug of choice for susceptible Enterococcus faecalis. However, for serious infections like endocarditis, synergistic combinations like ampicillin plus gentamicin or ceftriaxone are usually recommended because ampicillin alone might not be fully bactericidal against enterococci.
And finally, within the penicillins, we have the anti-pseudomonal penicillins. I understand these have a very specific and very important set of targets, particularly that difficult bug, Pseudomonas.
Yes, this class was specifically developed for even broader gram-negative coverage, primarily focusing on challenging pathogens like Pseudomonas aeruginosa and some other resistant gram-negatives. While older agents like ticarcillin are largely discontinued in the U.S., the most commonly used agent in this class today is piperacillin. And it's almost exclusively used in its co-formulation with the lactamase inhibitor tazobactam. Zosyn. Piperacillin tazobactam has the broadest antibacterial spectrum of the penicillins. Its activity includes good coverage against P. aeruginosa, many other gram-negative enteric rods, streptococci, enterococci, methicillin-susceptible S. aureus, MSSA, H. influenza, and important anaerobes like B. fragilis. Because of this broad spectrum, it's become an important agent for the treatment of patients with serious infections caused by gram-negative bacteria, especially infections acquired in the hospital, things like hospital-acquired pneumonia, complicated UTIs, intra-abdominal infections, and bacteremias where resistant bugs are a concern. However, there's a critical point of concern regarding ESBL-producing organisms, extended-spectrum beta-lactamase producers. While some of these organisms might test susceptible to piperacillin tazobactam in the lab, a notable randomized trial found increased mortality in patients treated with piptazo compared to those treated with the carbapenem, meropenem, for serious ESBL bloodstream infections. This highlights the complexity of interpreting susceptibility results and choosing the best therapy for these highly resistant infections. Piperacillin tazobactam is administered parenterally, and a strategy sometimes used to optimize its killing activity, especially against less susceptible bugs, is extending the infusion over 4 hours instead of the standard 30 minutes. This keeps the drug concentration above the bug's killing threshold for longer.
Okay, that covers the different types. Now let's talk about the downside again. The adverse reactions of penicillins in general. What's the biggest concern we need to be aware of across the class?
Without a doubt, the most clinically important adverse effects are hypersensitivity reactions. Penicillins are actually among the most common causes of drug allergy. These reactions can manifest in many ways, from a simple maculopapular rash, urticaria, hives, and fever, to much more severe conditions like bronchospasm, vasculitis, serum sickness, exfoliative dermatitis, Stevens-Johnson syndrome, and the most feared, anaphylaxis. Anaphylaxis, while relatively rare, occurring in maybe 0.0001% to 0.04% of treatment courses, is extremely serious, with deaths occurring in about 0.001% of patients who receive the drug. It most often follows injection, but can happen with oral use too. These allergic reactions are caused by penicillins and their breakdown products acting as haptens. They covalently bind to our own proteins, forming complexes that the immune system recognizes as foreign. This leads to the formation of major penicillyl moiety and minor antigenic determinants that trigger an immune response, often involving IgE antibodies for immediate reactions.
So if someone comes in with a history of penicillin allergy, how do we manage that significant risk? Can they ever receive penicillin again?
That's a really important clinical question. First, evaluation of the patient's history is the most practical way to avoid risk. Getting a detailed description of the previous reaction is key. However, it's a very common misconception that many patients labeled as penicillin allergic truly are. In fact, studies show that 90% or more of patients with a history of penicillin allergy will not manifest immediate hypersensitivity reactions on immunologic testing. Many reported allergies were actually side effects, viral rashes misattributed, or the allergy waned over time. For patients where there's genuine doubt or strong indication for penicillin, like neurosyphilis, skin testing can be performed using commercially available kits for the major determinant. A negative skin test has a very high negative predictive value, over 95%, for ruling out immediate Ig-mediated reactions. Now, for truly penicillin-allergic patients who must receive the drug, a process called desensitization is recommended. This involves administering gradually increasing doses of the penicillin, starting extremely low, usually in an intensive care setting where any reaction can be managed immediately. A critical point about desensitization. When full therapeutic doses are reached, the penicillin should not be discontinued and then restarted during treatment of the infectious episode because immediate reactions may recur. The desensitized state is temporary. Aside from allergies, penicillins generally have minimal direct toxicity, which is one of their advantages. However, other potential adverse effects, though less common, can include bone marrow depression and granulocytopenia, low white blood cell counts, especially with prolonged use of agents like nafcillin. Some penicillins, particularly at high doses, like penicillin G, piperacillin, have been associated with impaired hemostasis due to defective platelet aggregation, which is a potential concern for bleeding, especially in patients already at risk. And that crucial safety note regarding administration bears repeating. Intrathecal or intraventricular injection of penicillins or other lactams should be avoided due to the risk of severe and potentially fatal encephalopathy, brain dysfunction. Similarly, high CSF concentrations of penicillins achieved through excessive intravenous doses or unadjusted doses in patients with poor renal clearance can lead to CNS dysfunction, including confusion, twitching, and even seizures. Finally, like many broad-spectrum antibiotics, penicillins can significantly alter the normal gut microflora. This can eliminate sensitive organisms but allow resistant ones, like Clostridium difficile, to overgrow, leading to superinfection ranging from mild diarrhea to life-threatening pseudomembranous colitis.
All right, that brings us to the next major class of lactams, the cephalosporins. What defines them structurally, and how are they different from penicillins right at their core?
Cephalosporins are another large and distinct family of lactam compounds. Their core structure is containing 7-aminocephalosporanic acid. A key chemical difference from many basic penicillins is their inherent relative stability in dilute acid, and importantly, their resistance to penicillinase, regardless of their specific side chains or the enzyme's affinity. That was a major advantage early on. Similar to penicillins, modifications at position 7 of the PBPs ring alter antibacterial activity, determining which bacteria they hit best. And substitutions at position 3 of the dihydrothiazine ring, the other ring fused to the lactam, primarily alter the metabolism and pharmacokinetic properties, how the body handles the drug. There's also a closely related subgroup called cephomycins, which are similar but have a specific methoxy group at position 7, giving them slightly different properties, particularly resistance to certain vt-lactamases.
And how did cephalosporins actually come to be discovered? Was it another serendipitous moment like penicillin?
It was, in a way. The story begins in 1948 with an Italian scientist named Brazzu. He isolated a fungus, Cephalosporium acremonium, from the sea near a sewage outlet in Sardinia. He found that crude filtrates from this fungus remarkably inhibited S. aureus and apparently even, quote, cured staphylococcal infections and typhoid fever in humans. Subsequent work isolated 3 distinct antibiotics from it. The pivotal step, much like with penicillin, was the isolation of the core nucleus, 7-aminocephalosporanic acid. This allowed chemists to start adding different side chains, leading to the creation of numerous semi-synthetic compounds with antibacterial activity very much greater than that of the parent substance. This really opened the door for the diverse and powerful cephalosporin drugs we have today.
Okay, so given their structural similarity to penicillins both being lactams, do cephalosporins work in essentially the same way?
Largely, yes. The fundamental mechanism is the same. Cephalosporins and cephomycins inhibit bacterial cell wall synthesis in a manner similar to that of penicillin, that is, by binding to and inhibiting those critical penicillin-binding proteins, PBPs. However, there's a key difference in the details. Their specific PBP binding profiles differ somewhat from penicillins. They might bind more strongly to some PBPs and less strongly to others compared to a given penicillin. A really important consequence of this difference is the lack of binding of cephalosporins to essential PBPs and Enterococcus pp. Because they don't effectively inhibit the key PBPs and Enterococci, this entire class lacks clinically useful activity against these organisms. That's a fundamental limitation you always need to remember with cephalosporins.
And what about bacterial resistance to cephalosporins? Are the mechanisms pretty much the same as we saw with penicillins?
Yes, the fundamental mechanisms of resistance are quite similar. Resistance can arise due to the inability of the antibiotic to reach its sites of action, like poor penetration through the outer membrane in gram-negatives, or being pumped out by efflux pumps, or due to alterations in PBPs that reduce binding affinity. For example, S. pneumonia can become resistant to even third-generation cephalosporins through alterations in key PBPs, specifically PBP 1A and 2X. And as we mentioned, with the exception of the newer anti-MRSA agents like ceftaroline, most cephalosporins lack activity against methicillin-resistant staphylococci due to their inability to bind to the low-affinity PBP, PBP2A expressed by these organisms. However, just like with penicillins, arguably the most prevalent mechanism of resistance to cephalosporins is inactivation by hydrolysis of the lactam ring by bacterial lactamase enzymes, and the various cephalosporins have variable susceptibility to the lactamases. Some are inherently more stable than others.
You mentioned those inducible bactamases earlier in the context of resistance. Is that a particularly big problem for cephalosporins?
It's a very significant problem, yes. Many of the first through third generation cephalosporins, including workhorses like ceftazidime and ceftriaxone, are unfortunately susceptible to hydrolysis by these inducible, chromosomally encoded vt-lactamases. These vt enzymes are commonly found in formidable gram-negative organisms like Citrobacter, Enterobacter, and Pseudomonas. The inducible nature is tricky because the bacteria can ramp up production of the enzyme when exposed to certain lactams. This allows for the selection of mutants with high-level expression, stable derepression, which can rapidly lead to clinical resistance during therapy. Critically, these Class C enzymes are not substantially inactivated by classical β-lactamase inhibitors like clavulanate or tazobactam. This makes infections caused by AMPC overproducing bacteria particularly difficult to treat with many standard cephalosporins. Newer agents like cefepime, often called a fourth gen, and ceftolozane are designed to be less susceptible to hydrolysis by Class C ball-lactamases, giving them an advantage against these organisms. However, even these advanced cephalosporins are still susceptible to degradation by the really broad-spectrum enzymes like OXA or KPC-type carbapenems and metallo-β-lactamases. This is why the development of new ball-lactamase inhibitors like avibactam, which can inhibit AMPC, KPC, and some OXA enzymes, is so important. Avibactam significantly enhances the activity of ceftazidime when they are co-formulated, Avicaz.
Okay, that makes sense. Now, how do we typically classify cephalosporins? It seems like there are generations, but maybe it's getting complicated. And what are their general pharmacological characteristics? How does the body handle them?
Right. The classification has traditionally been by these unofficial generations, going from first to, well, now arguably fifth generation, based primarily on general features of antimicrobial activity, basically, which bugs they cover better. While newer agents make this simple generation scheme somewhat problematic, it's still commonly used, especially for the first three generations. Agents developed after the third generation are often differentiated by some notable activity, like anti-pseudomonal or anti-MRSA activity. A crucial point to remember is the general lack of activity across all cephalosporins against certain groups of organisms. They universally lack reliable activity against Enterococcus, L. monocytogenes, the atypical respiratory pathogens, Legionella, Mycoplasma, Chlamydophila, C. difficile, and Campylobacter jejuni. Just don't use cephalosporins for these. In terms of how the body handles them, ADME, many cephalosporins are absorbed readily after oral administration, like cephalexin and cefdinir, while others must be given intravenously or intramuscularly. Most are excreted primarily by the kidney through glomerular filtration and tubular secretion. Therefore, just like penicillins, the dosage should be reduced in patients with renal insufficiency to prevent accumulation and potential toxicity. There are exceptions, though. Cefoprazone and ceftriaxone have significant biliary excretion. Ceftriaxone in particular has mixed renal and non-renal elimination. Probenecid, that drug that blocks tubular secretion, slows the renal tubular secretion of most cephalosporins, just like it does for penicillins. Importantly, for treating infections of the central nervous system, several cephalosporins, most notably ceftriaxone, cefotaxime, ceftazidime, and cefepime, penetrate across inflamed meninges in sufficient concentrations to be clinically useful for treating bacterial meningitis. They also generally cross the placenta and are found in high concentrations in synovial and pericardial fluids.
Perfect overview. Let's break down the agent-specific antibacterial activity and uses by generation, starting logically with the first-generation cephalosporins like cefazolin and ceflexin. What's their main role?
Okay, first-generation cephalosporins have good activity against gram-positive bacteria, including most streptococci and, importantly, methicillin-susceptible S. aureus, MSSA. They also have modest activity against gram-negative microorganisms. However, key resistance points. Enterococci, MRSA, and most S. epidermidis are resistant. They cover most oral cavity anaerobes, but not B. fragilis. Their gram-negative activity is okay for things like E. coli and K. pneumonia, but probably not sufficient for severe infections. They notably lack activity against H. influenza. Cefazolin is the main parenteral IVIM agent in the U.S. It's well tolerated and is an excellent choice for many skin and soft tissue infections caused by S. pyogenes or MSSA. It's also the preferred agent for perioperative surgical prophylaxis for many procedures to prevent infection. Parenteral cefazolin is also used for serious MSSA infections like endocarditis, though nafcillin might be preferred by some. Oral agents like cephalexin are useful for mild to moderate upper respiratory infections like strep throat if penicillin allergy and uncomplicated urinary tract infections.
Okay, stepping up to the second-generation cephalosporins, like cefuroxime or maybe cefoxitin, how do they differ from the first generation?
The second-generation cephalosporins generally offer somewhat increased activity against gram-negative microorganisms compared to the first generation. This notably includes better activity against H. influenza, which the first generation missed. However, their overall gram-negative activity is still less than the third generation. There's a specific subset within this group, the cephamycins, cefoxitin, and cefotatem, which also have modest activity against the anaerobe B. fragilis. This gives them a niche. Cefoxitin and cefotin are technically cephamycins and are more resistant to some gram-negative lactamases. Generally, second-gen agents are less active against gram-positive bacteria than first-gen agents. Cefuroxime is a common example, available orally and IVM. It has good activity against H. influenza and meningitis and S. pneumonia, though maybe less than ceftriaxone. It lacks B. fragilis activity. Therapeutically, the second generation has largely been replaced by the third generation for many indications. Oral second-gen agents might still be used for respiratory tract infections, but they can be suboptimal for penicillin non-susceptible S. pneumonia. The main remaining niche is for cefoxin and cefotatin, which are useful in perioperative prophylaxis for intra-abdominal and gynecological surgical procedures because of that added anaerobic B. fragilis coverage.
Moving up the ladder again, the third-generation cephalosporins like cefotaxime and ceftriaxone seem to represent a big leap forward, especially against gram-negatives. What defines them?
That's correct. Third-generation cephalosporins were a major advance. They are generally much more active than prior generations against the Enterobacteriaceae, that large family of gram-negative rods, including E. coli, Klebsiella, Proteus, etc. However, a huge caveat now is that resistance is dramatically increasing due to the spread of β-lactamase-producing strains, like ESBLs. While generally less active against gram-positives than the first generation, key members like cefotaxime and ceftriaxone retain excellent anti-streptococcal activity, including against S. pneumonia, though resistance is emerging here too. Ceftriaxone is particularly notable for its very long half-life, around 8 hours, which allows for convenient once-daily dosing for most infections, twice daily for meningitis. It has mixed elimination, partly renal, partly biliary. These third-gen agents became the drugs of choice for serious infections caused by Enterobacteriaceae, assuming susceptibility. Ceftriaxone is specifically the therapy of choice for all forms of gonorrhea, though resistance is pushing doses higher, and for severe forms of Lyme disease. Both cefotaxime and ceftriaxone, given at high doses, are standard components for the empiric treatment of bacterial meningitis in non-immunocompromised adults and children, usually combined with vancomycin initially and maybe ampicillin if listeria is a concern. They are also excellent for the treatment of community-acquired pneumonia, often needing combination with an agent covering atypicals. But remember their limitations. No activity against L monocytogenes and potentially inadequate for highly penicillin-resistant pneumococcal meningitis.
Okay, now we get to the really heavy hitters for resistant gram-negatives. The anti-pseudomonal cephalosporins, sometimes called fourth generation or even beyond. These are for the really tough hospital bugs, right? Including Pseudomonas.
That's precisely their main role. This group includes agents like ceftazidime, often considered a third gen but with anti-pseudomonal activity, cefatuma, often called fourth gen, ceftolozane-tazobactam, ceftazidimia vivibactam, and the newer cefiderocol. Their primary value is their expanded gram-negative activity, most notably, including activity against P. aeruginosa. Some have weaker gram-positive activity than agents like ceftriaxone or simple ceftazidime, while cefepime retains good gram-positive coverage similar to ceftriaxone. Within this group, there are further specializations. Ceftazidime-avibactam and cefiderocol are particularly valuable because they are active against many extensively drug-resistant gram-negative pathogens, including those producing difficult carbapenems like KPC. Let's look at specifics. Ceftazidime has excellent activity against Pseudomonas, but is weaker against gram-positives. Its activity is significantly enhanced by avibactam against ESBL, KPC, and AMC-producing organisms. Ceftolozane is structurally similar to ceftazidime, but has enhanced activity against Pseudomonas, including some strains resistant to ceftazidime. It's co-formulated with tazobactam to cover ESBLs. Cephalosporin is really novel. It acts as a cytophore, binding iron and using bacterial iron transport systems to get inside, bypassing some common resistance mechanisms like porin loss and efflux, and it's stable to most vt-lactamases, including carbapenems and metallo-lactamases. It's reserved for highly resistant gram-negative infections. Cephalosporin is often considered the workhorse fourth gen. It has excellent activity against Antibacteriales like ceftriaxone plus Pseudomonas. It's also relatively resistant to hydrolysis by AMPC chromosomally encoded lactamases, making it useful against Enterobacter, Citrobacter, and Serratia that might be resistant to other cephalosporins due to AMP overexpression. However, it is susceptible to ESBLs and KPCs. Therapeutically, these agents are typically indicated for the empirical treatment of nosocomial infections where Pseudomonas and other resistant gram-negative bacilli are likely pathogens, such as hospital-acquired pneumonia, complicated UTIs, or intra-abdominal infections, where they'd be combined with an anti-anaerobic agent. The choice among them depends on local resistance patterns and the specific suspected enzymes, e.g. cephepm for AMP-C, ceftazidimia-bivactam, or cephalosporin for carbapenems producers.
And finally, within the cephalosporins, there's that newer class that's particularly exciting because it addresses a major resistance problem. The anti-MRSA cephalosporins. What makes them so special?
This was a significant breakthrough, yes. The anti-MRSA cephalosporins, which currently include ceftaroline, available in the U.S., and ceftobiprole, not in the U.S., are unique because of their structural modifications, allowing for binding to and inactivation of the altered PBPs expressed by MRSA, MRSE, and penicillin-resistant S. pneumonia. Remember PBP2A in MRSA, which normally has very low affinity for other β-lactams. These drugs can actually bind effectively to it. This is a game changer, restoring β-lactam activity against these critical pathogens. Ceftaroline fosmel, the prodrug form, has gram-negative activity comparable to cefotaxime, covering many common Enterobacterales and H. influenza. But its real distinguishing feature is its enhanced gram-positive activity, specifically against MRSA, over 95% inhibited, and penicillin-resistant S. pneumonia. Ceftaroline is given parenterally and is primarily eliminated by the kidneys. These agents are typically used for patients with documented or suspected severe infections where resistant Staphylococci or Streptococci are likely culprits. Ceftaroline is approved for community-acquired pneumonia and complicated skin soft tissue infections, especially when MRSA is suspected or confirmed.
Okay, that covers the vast landscape of cephalosporins. With such a wide range of agents, what are the common adverse reactions we need to be aware of across this class? Are they similar to penicillins?
Yes, the adverse reaction profile shares similarities with penicillins, but also has some unique aspects. The greatest concern, again, are hypersensitivity reactions, although these are generally less frequent overall than with penicillins. Manifestations can range from immediate reactions such as anaphylaxis, bronchospasm, urticaria, to delayed reactions like a maculopapular rash appearing after several days, sometimes with fever or eosinophilia. Now, that crucial question of cross-reactivity with penicillins. Current understanding suggests the likelihood of a patient with a penicillin allergy reacting to a cephalosporin is primarily determined by reactions to lactam side chains, not the core lactam ring structures themselves. If the side chains are identical or very similar between a specific penicillin and a specific cephalosporin, the risk is higher. If the side chains are different, the risk is generally considered low, perhaps 1 to 3%. So, for a history of a mild or distant penicillin reaction, the risk with a cephalosporin is low. But for a history of severe, immediate penicillin reaction, anaphylaxis, cautious use, potentially involving skin testing or a graded challenged dose protocol, is generally advised if a cephalosporin is necessary. Other adverse effects are generally less common. A positive Coombs reaction, detecting antibodies on red blood cells, can occur, especially with large doses, but actual hemolysis, red blood cell destruction, is rare. Bone marrow depression, like granulocytopenia, is also rare. Direct renal toxicity is uncommon with currently used cephalosporins at recommended doses, though historically some older agents were more problematic. Diarrhea can occur perhaps more frequently with agents having greater biliary excretion like cefoperazone. Ceftriaxone has a couple of specific issues. Its high binding affinity for serum albumin may displace bilirubin, which can potentially cause or worsen jaundice in neonates. Hence, cefotaxia is often preferred in newborns. Also, because ceftriaxone reaches high concentrations in bile and has an affinity for calcium, it can lead to the formation of biliary pseudolithiasis or sludge in the gallbladder. Certain cephalosporins containing a specific chemical group, thiotetrazole side chain, like sphitogen cefoperazone, can interfere with vitamin K metabolism and prolong the prothrombin time, potentially causing bleeding, especially in patients with underlying vitamin K deficiency or those on anticoagulants. Lastly, there have been reports of encephalopathy and non-convulsive status epilepticus associated with cefepime use, particularly in the context of high doses, underlying renal dysfunction leading to drug accumulation, or pre-existing brain injury.
Okay, beyond the massive classes of penicillins and cephalosporins, we still have other important β-lactam antibiotics to cover. Let's explore the carbapenems first. What makes them unique and so potent within the broader β-lactam family?
Carbapenems are indeed a distinct and incredibly powerful class of β-lactams. Structurally, they contain a unique fused β-lactam ring system where a carbon atom replaces the sulfur atom found in penicillins. This structural variation gives them generally the broader spectrum of activity than most other β-lactam antibiotics. A key reason for this breadth is their greater resistance to lactamase-mediated hydrolysis compared to many penicillins and cephalosporins. They are stable against many common β-lactamases, which makes them invaluable against many resistant bacteria.
Let's start with imipenem cilastatin and the newer combination with relebactam. How do they work? What are their strengths and why the combinations?
Right. Imipenem was the first carbapenem developed. It's always formulated in combination with cilastatin. Cilastatin itself has no antibacterial activity. Its sole purpose is to inhibit the degradation of imipenem by a renal tubular dipeptidase called DHP1. Without cilastatin, imipenem would be rapidly broken down in the kidneys, reducing its effectiveness and potentially increasing toxicity. Cilastatin essentially extends its half-life and ensures adequate drug delivery. More recently, imipenem cilastatin is also available co-formulated with the new β-lactamase inhibitor relebactam, or Carbrio. Relebactam significantly extends its spectrum against organisms producing certain carbapenems, particularly the KPC type, although it doesn't cover metallo-lactamase producers. Imipenem itself is highly resistant to hydrolysis by most common β-lactamases, though not carbapenems, and boasts excellent in vitro activity across a wide variety of aerobic and anaerobic microorganisms. This includes Streptococci, even penicillin-resistant S. pneumonia, Enterococcus faecalis, though not E. faecium, Staphylococci, but not MRSA, and Listeria. Its activity is generally excellent against the Enterobacterales, except for those emerging carbapenems-producing strains. Most Pseudomonas and Acinetobacter are inhibited, but resistance is definitely increasing and can even emerge during therapy for these organisms. It also has great activity against anaerobes, including B. fragilis. Because of this very broad spectrum, imipenem cilastatin's primary role is often the empirical treatment of serious infections in hospitalized patients who are at risk for resistant pathogens, like complicated intra-abdominal infections, hospital-acquired pneumonia, or febrile neutropenia. The imipenem-relebactam combination is specifically reserved for infections suspected or known to be caused by KPC-producing organisms where other options are limited. A key adverse effect historically associated with imipenem is seizures, observed in up to 1.5% of patients in early studies, particularly at high doses, in patients with underlying CNS lesions or those with renal insufficiency leading to drug accumulation. Nausea and vomiting upon infusion are also relatively common.
Okay, what about meropenem and its combination with vaborbactam? How does meropenem compare to imipenem?
Meropenem is another widely used carbapenem derived from therapeutic like imipenem. A key difference is that meropenem does not require co-administration with cilastatin because it is stable to that renal dipeptidase, DHP1. It's also now co-formulated with the β-lactamases inhibitor vaborbactam, Vabomera. In terms of spectrum, meropenem is broadly similar to imipenem, but with some nuances. Meropenem is generally considered somewhat less active against certain gram-positive organisms, particularly Enterococcus faecalis, but potentially more active against some gram-negative organisms, including potentially Pseudomonas. The addition of vaborbactam significantly restores the susceptibility of meropenem against a large subset of carbapenems producing gram-negatives, particularly those producing KPC enzymes similar to relebactam for imipenem. Pharmacokinetically, meropenem is given AIV, renally cleared, with a half-life around 1 hour. An administration strategy sometimes used, similar to piperacillin tazobactam, is extended infusion over 3 hours, which can improve its killing activity against pathogens with slightly elevated MICs. Regarding toxicity, meropenem's profile is similar to that of imipenem, except that it may be less likely to cause seizures. This lower seizure potential means meropenem is often preferred for treatment of meningitis when carbapenem therapy is required, as high CNS concentrations are needed. Meropenem is typically employed for similar indications as imipenem serious hospital-onset infections, respiratory, GI, UTI, where resistant gram-negative or mixed infections are suspected. Meropenem verbactam is specifically reserved for documented or highly suspected multi-drug-resistant gram-negative pathogens, particularly KPC producers. A notable drug interaction is that carbapenems can significantly lower serum concentrations of valproic acid, an anti-seizure medication, so they should not be co-administered.
And then there's ertapenem, which you mentioned seems to have some distinct differences from the other carbapenems, particularly in dosing and spectrum.
Indeed, ertapenem stands out primarily because it has a significantly longer half-life that allows once-daily dosing, which is a major advantage for patient convenience, especially for outpatient therapy. However, this convenience comes with a narrower spectrum compared to imipenem or meropenem. Ertapenem notably lacks clinically useful activity against Enterococcus, P. aeruginosa, and Acinetobacter spp. Those are key pathogens it doesn't cover well. Its strength lies in its excellent activity against most enterobacteriales, including ESBL-producing isolates and common anaerobes. This makes it particularly useful in community-acquired or less severe hospital-acquired intra-abdominal infections or complicated UTIs where Pseudomonas or Enterococcus are not primary concerns. Its once-daily dose, 1 GIV, really facilitates outpatient antibiotic therapy, OPBAR. It also appears to have a lower seizure risk than imipenem.
Okay, that covers the carbapenems. What about the other class you mentioned, monobactams? They sound like a very specific, maybe structurally simpler kind of lactam.
They are structurally unique, yes. Monobactams are lactams that contain only a fused lactam ring. They lack the second fused ring, thiazolidine or dihydrothiazidine, found in penicillins and cephalosporins. Currently, Aztreonam is the only member of this class in therapeutic use. Its resistance profile is interesting. It's generally resistant to hydrolysis by many narrow-spectrum lactamases from gram-negatives, and importantly, resistant to hydrolysis by metallo-lactamases. However, it is susceptible to hydrolysis by most ESBLs and KPC-type lactamases. Aztreonam's spectrum is incredibly narrow and specific. It has activity only against gram-negative bacteria. It has essentially no activity against gram-positive bacteria and anaerobic organisms. Its gram-negative activity against Enterobacterales and P. aeruginosa is generally considered similar to that of ceftazidime. It's also highly active in vitro against H. influenza. Aztreonam is given parenterally, IM or IV, or via an inhaled formulation. Its half-life is about 1.7 hours, and it's primarily excreted unchanged in the urine, so the half-life is prolonged significantly in patients with kidney failure. The most notable feature and the primary clinical niche for Aztreonam is its lack of allergic cross-reactivity with other lactam antibiotics, with the possible exception of agents sharing a similar side chain like stazidime. This unique characteristic makes Aztreonam exceptionally useful for treating serious gram-negative infections among patients with documented severe hypersensitivity reactions, like anaphylaxis to other lactam classes, such as penicillins or cephalosporins. It also has a growing role in the treatment of metallo-lactamase-producing organisms because it's stable to these problematic enzymes. It's often co-administered with ceftazidime avibactam in these situations, as avibactam can cover other coexisting lactamases like KPC or ESBLs, and specific Aztreonam-amectin combination products are in development. The inhaled formulation is specifically used to reduce the frequency of Pseudomonas-associated pulmonary exacerbations in patients with cystic fibrosis. Adverse effects are generally mild, though hepatotoxicity has been reported, especially in infants.
Okay, we've covered the vast world of lactams in incredible detail. But as you mentioned at the start, there are other important classes of antibiotics that also target the cell envelope, but work in completely different ways. Let's start with the glycopeptides. What are the key players here?
Right. Glycopeptides represent another mechanism by which the cell wall synthesis pathway in bacteria can be targeted, distinct from the olactans PBP inhibition. The class originator and the most well-known member is vancomycin, isolated from Streptomyces orientalis. There's also teicoplanin, used mainly in Europe. More recently, a new generation of glycopeptide congeners, the lipoglycopeptides, have been developed and introduced. These include telavancin, dalbavancin, and oritivancin. They build upon the vancomycin structure but add lipid side chains.
And how do glycopeptides actually work? What's their mechanism of action?
Glycopeptides inhibit cell wall synthesis in sensitive bacteria through a different interaction. They achieve this by non-covalent high-affinity binding to the adenyl terminus of cell wall precursor units. Remember those building blocks made inside the cell? Glycopeptides bind right onto the end of them. This binding action directly blocks through steric hindrance both the transglycosidase-mediated polymerization step, linking the sugar units together, and the PBP-mediated cross-linking step, linking the peptide chains. So it blocks two crucial steps in building the wall, but by binding the substrate, not the enzyme like glycopeptides do. Now, because of their large molecular size, glycopeptides are generally unable to penetrate the outer membrane of gram-negative bacteria. This physical barrier explains their lack of activity against most gram-negatives. They simply can't reach their target. The newer lipoglycopeptides, televancin, delavancin, or hidovancin, have an enhanced mechanism. They can dimerize and anchor their lipid moieties into the bacterial membrane. This helps increase their binding to the dala target and generally improves their potency compared to vancomycin. Even more interestingly, telavancin and oritovancin possess a second mechanism of action: direct disruption of the bacterial membrane potential, similar in concept to daptomycin, which we'll discuss next. This can lead to more rapid bactericidal activity than that of vancomycin alone.
Okay, so primarily gram-positive activity. What's the specific antimicrobial activity of these drugs, particularly the workhorse, vancomycin?
Vancomycin possesses reliable activity against the vast majority of gram-positive bacteria. This includes critically important pathogens like MRSA, penicillin-resistant streptococci, and many ampicillin-resistant enterococci, E. faecium more often than E. faecalis. There are some gram-positive bacteria that have intrinsic resistance, like lactobacillus or leuconostoc, and as we discussed, essentially all species of gram-negative bacteria and mycobacteria are resistant to glycopeptides. The newer lipoglycopeptides generally have activity similar to vancomycin against susceptible organisms. An important potential advantage is that telavancin, dalbavancin, and ortavancin also retain activity against some vancomycin-resistant enterococci, VRE, particularly those with the VAN-B genotype.
And that leads us directly into the significant problem of resistance to glycopeptides. I know vancomycin-resistant enterococci, or VRE, are a major hospital-acquired infection concern. How does that resistance work?
Absolutely. VRE, particularly glycopeptide-resistant strains of enterococci, primarily Enterococcus faecium, have emerged as major nosocomial pathogens. A key reason is that their resistance determinants are often located on a transposon that is readily transferable between bacteria via plasmids. These VRE strains are also typically resistant to multiple other antibiotics. The mechanism of enterococcal resistance is quite ingenious and well understood. It's the result of alteration of the D-alanyl D-alanine target to either D-alanyl D-lactate or D-alanyl D-serine. These altered termini bind glycopeptides poorly, essentially removing the drug's binding site. This requires a cluster of genes, the VAN gene cluster, to synthesize these altered precursors. There are different genotypes like VANA, high-level inducible resistance to both vancomycin and teicoplanin, and VAN-B, lower-level resistance, inducible by vancomycin but not teicoplanin. Lipoglycopeptides often retain activity against VAN-B strains, but VAN-E strains can be problematic, especially for dalbavancin. Beyond enterococci, staphylococcal resistance to vancomycin is also a major clinical concern. We see S. aureus strains expressing reduced or intermediate susceptibility to vancomycin, VISA, with MICs slightly elevated, 4 to 8 mg/mL. This often emerges after prolonged vancomycin exposure. Even more concerning, though thankfully still very rare, are high-level vancomycin-resistant S. aureus VRSA strains with MICs 016 mg/mL. These strains have actually acquired the entire VAN-A transposon, usually via horizontal gene transfer from VRE co-infecting the same patient. The emergence of VRSA is a major public health threat, giving vancomycin's role in treating MRSA.
Okay, that's concerning. How are these glycopeptides administered, and how does the body process them? ADME.
Right. A key point is that all glycopeptides are poorly absorbed after oral administration. They are large, polar molecules. This is precisely why oral vancomycin is exclusively used in patients with C. difficile colitis. It stays in the gut where the infection is, acting locally. For systemic infections, vancomycin must only be administered intravenously, not intramuscularly, due to pain and potential tissue necrosis. It distributes reasonably well into various body fluids, including inflamed CSF, though penetration is variable, bile, pleural, pericardial, and synovial fluids. Vancomycin is primarily excreted by glomerular filtration in the kidneys. Its elimination half-life is about 6 hours in adults with normal renal function. Because of this renal clearance, the drug accumulates if renal function is impaired, and dosage adjustments must be made based on kidney function or therapeutic drug monitoring. It is cleared by hemodialysis to some extent. Teicoplanin, used in Europe, has an extremely long serum elimination half-life up to 100 hours, allowing for convenient once-daily dosing after a loading period. The newer lipoglycopeptides dalbavancin and orithavancin have truly unique pharmacokinetic properties that allow for intermittent, weekly or less, dosing. They have extremely long plasma half-lives, with terminal elimination half-lives on the order of 10 days or more. Dalbavancin requires dose adjustment for renal dysfunction, while orithavancin, due to very slow excretion, does not. This infrequent dosing is a major potential advantage for patient convenience and adherence, especially for outpatient therapy. Telavancin has a more typical half-life, 7 hours, requiring daily dosing and renal adjustment.
With that context, what are the main therapeutic uses for these glycopeptides, especially vancomycin, and how is it dosed and monitored now?
For vancomycin, standard initial adult doses for systemic infections are typically in the range of 30–45 mg/kg per day, divided into 2 or 3 doses, with significant adjustments needed for impaired renal function. For patients on dialysis, dosing is often timed around dialysis sessions. As mentioned, oral vancomycin is the drug of choice for C. difficile colitis, with standard doses of 125 mg 4 times daily, potentially escalated for severe cases. Monitoring vancomycin therapy has evolved. Traditionally, trough serum concentrations, levels drawn just before the next dose, were targeted, aiming for U10 mg/ml generally, or 15–20 mg/ml for serious infections like endocarditis or MRSA pneumonia. However, newer guidelines now recommend targeting an area under the curve, AUC to MIC ratio, specifically aiming for an AUC between 400 and 600 mg/L for serious MRSA infections. This AUC-based monitoring is thought to better correlate with efficacy and potentially reduce nephrotoxicity compared to high trough targets alone. It typically requires drawing a couple of levels during a dosing interval and using pharmacokinetic calculations, often via specialized software, to estimate the AUC. Telavancin is given as 10 mg daily 5e, adjusted for renal function. Dalbavancin is approved for skin soft tissue infections either as a 2-dose regimen, 1,000 mg and 500 mg a week later, or as a single 1,500 mg IV dose. Orithavancin is also approved for skin soft tissue infections as a single 1,200 mg IV dose. These long-acting agents offer simplified treatment regimens. Clinically, vancomycin has long been a mainstay for skin soft tissue and bone joint infections, especially when MRSA is suspected or confirmed. The lipoglycopeptides offer alternatives, particularly dalbavancin and orithavancin, for their infrequent dosing convenience. For respiratory tract infections, vancomycin is used for pneumonia when MRSA is suspected, though lung penetration can be limited, requiring adequate dosing. Telavancin showed similar efficacy in studies. In CNS infections, vancomycin is a key component of empiric therapy for community-acquired bacterial meningitis, covering potential penicillin-resistant pneumonia, and is used for nosocomial meningitis, often caused by Staphylococcus. For endocarditis and vascular catheter infections, vancomycin is standard therapy for MRSA endocarditis or in penicillin-allergic patients with susceptible organisms. However, it's crucial to remember that for MSSA bloodstream infections, β-lactams such as nafcillin or cefazolin are more effective than vancomycin, so vancomycin should only be used if there's a documented life-threatening vancomycin allergy. Vancomycin, often with an aminoglycoside, is also used for some enterococcal endocarditis cases.
That covers their uses. What are the main adverse effects associated with glycopeptides that we need to watch out for?
The most well-known adverse effect specifically linked to vancomycin infusion is the infusion-related reaction, often called red man syndrome, or sometimes less accurately, or redneck syndrome. This happens with rapid intravenous infusion of vancomycin and causes characteristic erythematous or urticarial reactions, redness, hives, flushing, tachycardia, and occasionally hypotension. Importantly, this is not typically an allergic reaction, but rather a pseudo-allergic reaction caused by a direct effect of vancomycin on mast cells, causing them to release histamine. It can usually be ameliorated by administering vancomycin more slowly, for example, over at least 60 minutes or longer for larger doses, and sometimes by premedication with antihistamines. Similar, though perhaps less frequent, reactions have been reported with the lipoglycopeptides like telavancin. Nephrotoxicity, kidney damage, is another concern. While older, less pure formulations were clearly nephrotoxic, it's now understood that there is indeed a degree of dose-related nephrotoxicity with current vancomycin, especially with the higher doses and target levels used for serious infections, or when co-administered with other potentially nephrotoxic drugs like piperacillin-tazobactam, aminoglycosides. Televancin's potential for nephrotoxicity might exceed that of vancomycin based on some data, other toxicities. True hypersensitivity allergic reactions to vancomycin are less common than the infusion reactions but can occur, rashes, rarely anaphylaxis. A concern with the very long-acting agents, dalbavancin or Davancin, is that if a severe hypersensitivity reaction occurs, managing it could be complicated by the drug's prolonged presence. Telavancin carries a warning for QT interval prolongation on the ECG and is contraindicated in pregnancy due to terogenic effects observed in animal studies. Ototoxicity, auditory impairment, sometimes permanent, has been associated with vancomycin, typically with excessive plasma concentrations, historically 60-80 vg/ml. Orativancin can interfere with certain coagulation tests and requires careful monitoring with warfarin.
Okay, that's a thorough look at glycopeptides. Now let's move to the lipopeptides, with daptomycin being the sole member in this class currently. How does it fit into the picture of cell envelope disruptors? It sounds somewhat similar to the lipoglycopeptide secondary mechanism.
Yes, there are some conceptual similarities in targeting the membrane. Daptomycin is a unique cyclic lipopeptide antibiotic originally isolated from Streptomyces roseosporus. Its key clinical value is that it's rapidly bactericidal against gram-positive bacteria, including vancomycin-resistant isolates like VRE and potentially Visa-VRSA, making it incredibly valuable for these difficult infections. Its antimicrobial activity is selectively active against aerobic, facultative, and anaerobic gram-positive bacteria. Importantly, like glycopeptides, daptomycin lacks clinically useful activity against gram-negative organisms. It can't penetrate their outer membrane. Its mechanism of action is quite distinct from both lactamins and glycopeptides. Daptomycin inserts its lipid tail into the bacterial cytoplasmic membrane in a calcium-dependent manner. This binding then causes a rapid depolarization, loss of membrane potential, and subsequent cell death due to inhibition of protein, DNA, and RNA synthesis. It essentially short-circuits the bacterial membrane. Its killing activity is concentration-dependent.
What about resistance to daptomycin? Does that emerge, and how might we overcome it?
Unfortunately, yes, daptomycin resistance has been reported to emerge while on therapy, particularly in the context of high inoculum infections like endocarditis or foreign body infections, and it's especially a concern with enterococci. The exact mechanisms of resistance to daptomycin have not been fully characterized, but appear to be related to complex changes in the cell membrane composition and cell surface charge that impede daptomycin binding or insertion. Now, what's fascinating and a potentially crucial insight from recent research is the observation that co-administration of certain β-lactams with daptomycin, even when the pathogen is technically resistant to the all-lactam itself, can sometimes reverse this daptomycin resistance or prevent its emergence. This phenomenon is called seesaw susceptibility, or wall-lactam rescue. The exact mechanism isn't fully clear, but it might involve the lactam altering the cell wall, or PBPs, in a way that resensitizes the membrane to daptomycin. Early clinical data suggest these combinations may be effective in treatment of severe staphylococcal and enterococcal infections, offering a novel strategy, especially for difficult cases like VRE bacteremia or refractory MRSA infections.
That's really interesting, using one drug to help another work better. How is daptomycin administered, and are there any unique limitations or considerations?
Like glycopeptides, daptomycin is poorly absorbed orally and should be administered intravenously. Because it can cause direct toxicity to muscle, intramuscular injection is precluded. Its serum half-life is reasonably long, around 8 to 9 hours, allowing for convenient once-daily dosing. About 80% is recovered in the urine, so renal elimination is important. A really key limitation you absolutely must remember with daptomycin is that it is inactivated by pulmonary surfactant. Surfactant is the substance lining the alveoli in our lungs. This inactivation means daptomycin is not useful in the treatment of pneumonia. You simply cannot use it for lung infections. It won't work there. Because it's renally eliminated, if a patient's creatinine clearance is less than 30 millinol/nib, the dose needs to be given less frequently, typically every 48 hours. For patients on hemodialysis, it's usually given immediately after the dialysis session. Therapeutically, daptomycin is indicated for treatment of complicated skin and soft tissue infections, and also for complicated bacteremia and right-sided endocarditis caused by susceptible gram-positive organisms, including MRSA and VRE. Its efficacy is generally comparable to vancomycin or standard antistaphylococcal lactams for susceptible pathogens. While originally approved at doses of 4 to 6 milligauss daily, higher doses, 8-12 milligauss daily, are now often recommended and appear well tolerated, particularly for invasive staphylococcal or enterococcal infections, to maximize efficacy and potentially reduce resistance emergence.
And what are the main adverse effects to monitor with daptomycin?
The most characteristic adverse effect is musculoskeletal toxicity, manifesting primarily as elevations of creatine kinase, CK levels in the blood. Muscle pain or weakness, myopathy, can occur. Routine CK monitoring is often recommended, perhaps weekly. Discontinuation is generally needed only if CK levels rise significantly, for example, 10 times the upper limit of normal, or if the patient develops unexplained myopathy with elevated CK. Rhabdomyolysis, severe muscle breakdown, is rare but possible. A rare adverse effect that has been described is eosinophilic pneumonia, an allergic type lung reaction. In terms of drug interactions, daptomycin doesn't significantly affect major CYP enzymes. However, caution is advised when using it concurrently with aminoglycosides due to potentially increased nephrotoxicity risk, and with statins, cholesterol-lowering drugs, due to the potential for additive myopathy risk, though concurrent use is often managed carefully.
Okay, perfect. And finally, let's just briefly touch on bacitracins. I mostly know these from topical antibiotic ointments like Neosporin. Is that their main use?
That's precisely right. Bacitracin is actually a mixture of related polypeptide antibiotics produced by Bacillus subtilis. The major active component is bacitracin A. Its mechanism involves inhibiting cell wall synthesis by interfering with the recycling of the lipid carrier molecule that transports cell wall precursors across the cell membrane. Its spectrum includes various gram-positive cocci and bacilli, as well as some gram-negatives like Neisseria in H. influenza and Treponema pallidum. However, Enterobacteriaceae and Pseudomonas are resistant, but as you noted, its current use is largely restricted to topical application. You find it in numerous ophthalmic and dermatologic ointments and creams, often in combination products with other topical antibiotics like neomycin or polymyxin B, sometimes with local anesthetics too. It's used topically for eradicating sensitive bacteria in open infections like infected eczema or dermal ulcers, or for eye infections like suppurative conjunctivitis. Attempts to use it intranasally to eradicate staphylococcal carid have had limited success. Hypersensitivity reactions are rare. The main reason for its topical restriction is its most significant adverse effect. Its significant nephrotoxicity results from the parenteral use of bacitracin.
Yeah.
Because it can damage the kidneys when given systemically, its use is essentially confined to putting it on the skin or in the eye. Hashtag outro.
Wow, what an incredibly detailed journey. We've really peeled back the layers of bacterial defenses, haven't we? And seen firsthand how precisely these different classes of cell envelope disruptors actually work. From that, ancient mold that gave us penicillin right up to the latest lipoglycopeptides and the lactamase inhibitor combinations designed to tackle truly formidable resistance, it's crystal clear that this is a constantly evolving dynamic battle.
Indeed it is. We've covered a lot of ground. We've traversed the intricate pathways of peptidoglycan synthesis. We've understood the incredibly clever ways bacteria fight back, mutating their PBPs, deploying those efflux pumps, unleashing a bewildering array of villactamases. And importantly, we've explored how we, in turn, have responded by developing new drug classes, new generations within classes, and those crucial lactamase inhibitors, each with its own unique profile of strengths, weaknesses, and challenges.
Absolutely. So after this deep dive, you really should understand not just that these drugs work, but how they work at a molecular level, why resistance emerges and spreads, which is so critical, and the specific clinical scenarios where each class or agent shines or where it struggles. You've truly gained a profound level of insight on this topic, going way beyond the headlines to really master the core details, much like the elite professionals in this field constantly strive to do.
And reflecting on all this deep dive really highlights an important, maybe even slightly unsettling question for the future. As bacterial resistance inevitably continues to evolve, especially with the frightening emergence of multi-drug, pan-drug resistant strains, what new targets within the bacteria or what truly novel therapeutic approaches, perhaps things beyond even what we've discussed today, might humanity need to discover and develop to stay ahead or even just keep pace in this critical, unending arms race against these ever-adapting microbes?
That is a perfect thought to mull over. It really underscores that while we've gone incredibly deep today, the science of pharmacology and infectious disease is always pushing forward, always demanding continuous innovation and vigilance. Thank you so much for joining us on this deep dive. We genuinely hope you feel more knowledgeable, more empowered, and perhaps even more curious than ever about this vital area of medicine.